I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin, and I'm really thrilled to be joined by a dear friend and colleague, Taweesak from Bangkok, from Thailand. You've been a pioneer in educating us about the surgical treatment of patients with rheumatic heart disease. What about, so I want to extend that and say the young people with significant rheumatic valvular disease. Tell us what your approach is.
Yeah, sure. First of all, thank you very much, Randy, for inviting me. Well, the young in my country and the whole region, and I think a lot of young people all over the world, still in many countries, still in the need to have a good treatment for rheumatic heart disease.
Right.
Yeah. Just recently, we just make a very brief overview. It's something like another 15 to 20 million people still waiting.
For treatment?
For the treatment.
Ooh, that's amazing.
Yeah.
So how do we treat that? In other words,
Well, when the medical treatment has failed or something like that, and then they're subject to surgery, most of them, I have to say that most of them get valve replacement.
right.
Yeah. And with that age group, most of them got the mechanical valve,
Right.
which actually is not bad, but by itself carries some inherent complication
Sure.
that due to the need of long-term anticoagulation, that's a big problem
This is a big problem.
because it can create some complication, bleeding or thrombosis or some neurological emboli, something like that, in the young, which will subject them to longer time. So this is a big problem.
But so that you pioneered and really have taught many colleagues around the world how to repair these valves.
Yeah.
Which sounds counterintuitive to, from my early echo days, seeing somebody who had the consequences of rheumatic mitral stenosis or severe valvular disease with the valve all scarred down. Tell me a little bit about the surgical approach in the young patient with rheumatic and mitral valve disease.
Yes, actually, the repair in rheumatic has been pioneered by several previous pioneers, like Kapong there, like McCool, like many. But most of them are still at that time confined mostly to rheumatic MR.
Right.
Now, for the mixed type MS-MR or MS, it's still big questions. Now, this is the big problem because there's still a lot of young people with this type.
Right.
So, in order to move forward, we have to base on their work, understanding about how the valve work in both diastolic and systolic. So, to repair that, we need to restore the normality of both phases because that is the only way that the valve can function well. Now, this is a big issue. How to restore all of this back with the valve is stiff, shrunken, stenosis with a lot of subvalvular problem.
Right.
Now, based on their previous study, gradually we found a way how to open, how to correct all of this restriction, all the thick, and how to mobilize it and make them work good in both phases.
So, and I know that, and I've heard you talk about that. Tell our viewers a little bit about. So, how do you do that? I don't want and it's not simple, but in simple terms, you've got to change. You've got to affect the body of the leaflet so they have some mobility. You've got to do all the subvalvular apparatus, and open up the commissures and all. So, tell me, sort of, how do you do that?
It's just like with the more experience that we have been doing this type of operation. I think that I would like to call it the car assembly approach. That means Because the mitral valve complex has so many segments.
Correct.
So if you start something like, to me, like we start always with full commissurotomy.
Okay.
That is the only way that we can assess the mobility in
Got it.
every segment. And then we mobilize mostly start from the posterior, cut restrictive cord out. Posterior, then anterior, and then correct the fan shape of the both commissures so that they can move in a very good way. And then after cutting all of these restrictive or obstructive cord out, we peel the leaflet that used to be thickened by the rheumatic process out. Then the valve becomes pliable and move in the normal way and then strengthened by the ring. So with this step, commissurotomy, mobilization, posterior to anterior, fenestration, peeling, put in the ring. At the end, it becomes a good valve.
That's phenomenal. It's
Yes.
phenomenal. And the durability is good with these. I mean, it obviously depends on the case, but you've had really good outcomes with these.
Yeah, this is another subject that people are questioned about that because the previous result is not very encouraging, especially for mixed type and stenotic type. That is because in the past I believe that the surgeon just do not enough. They just do the simple commissurotomy and a little bit of the papillotomy, and then the valve move in the, I call it the slit like, it's just like that. It doesn't fool like that. So the way we do is try to mobilize every single part, holistic
Got it.
repair.
Got it.
Then the valve open like that and close like that. With this, it will be good in terms of physiology to make them durable because they are protective mechanisms that they can achieve. We can achieve with all of these measures. And I think with this, for at least for the young adult, they should be more or less close to the degenerative result. We only have the very small children that we have to think about how the active process of rheumatic can interfere with all of this. This is another story.
And you're talking about really young children with this, so that's a more difficult scenario,
Yeah.
isn't it?
Yeah.
Do you think is this your techniques? You've gone over the world and taught people, and do you see this spreading to other areas of the world? I mean, people in Africa and India and places like that. There's more and more repair of the young people with this versus replacement.
Yes. The wave of enthusiasms in repair, in rheumatic, especially in the young, now getting better and better belief.
Right.
Previously, they have a lot of questions. They're uncertain about the future. They don't know what to do, which type of technique. And actually, our technique is still evolving. Something like those patients with a lot of calcification. We used to be chop it out, put in the autologous pericardium, press a lot of the cortex. But now we found a way how to peel the calcium out
That's amazing.
and leaving only the natural tissue,
Amazing.
which is good for especially in the young kid because they live with their own tissue, which is more durable. So all of this, I think that the momentum keep going in the right way, that people try at least to repair. They cannot repair all at first,
sure,
but
sure,
it's okay.
sure.
And when you get started, you can repair more and more because you believe it. You
And
can see
you
it.
get more experience.
Yeah,
You
and
get-
we have the network. We set up a network between those surgeons who are interested in
Right.
sharing and then convince and inspire each other.
That's fabulous. Well, I've had the pleasure of being in Bangkok and seeing the impact that you've had, not only in your country, but with all the colleagues around the world. And so I certainly appreciate it. And I know the thing that's most meaningful is watching you interact with patients and their families, because I've been able to go to hospitals where you operate. So congratulations. Thank you. Keep up the good work, because you're doing.
Thank you
you're
very
helping-
much.
Helping all of us by that So thanks very much.
Thank you very much. You are my inspiration as well. Thank you, Randy.
Thank you. And thank you for joining us.
Thank you.